This is the agenda for today. We're going to talk about a variety of topics, some of the key news coming out of ACG this year, and put it in some of the context of Canadian practice so that hopefully you can take this learning home. So what are the goals of the CARE program? It's really to allow us to all to interact at these international meetings, to some extent build networks of people who've attended the meetings online and in person as well. And but as I mentioned, it's really to try to put news coming out of the ACG and also at DDW into a Canadian practice context. And we've done a lot of work over the years with trainees, trying to highlight some opportunities for further training or some advice in going into practice. And with that, we've hopefully helped with some mentorship as well. So, as mentioned, the physical meetings for CARE are only really part of what we do. We are present on social media. I'm not sure I understand what all these things are, but I think that's Twitter with a hashtag. I think that's LinkedIn. Is that LinkedIn? Right, that is LinkedIn. And something else at the bottom, which I guess is our website. That W means internet, right? So, okay. All right, so we also have our website. In fact, the website's important because afterwards you can go online and access all the CARE programs. And I think through that website, you'll be able to access the online content through our YouTube channel, again, for the people listening online and for the people who want to catch up on this after the actual meeting. We also do produce, after each meeting, conference report. And all the speakers contribute to these reports that are printed in hard copy and are distributed by mail to gastroenterologists across Canada, summarizing, again, the news coming out of these meetings. We also try to produce navigation guides for people going to the meetings to try to tell them where the hot news is and where to be, depending on your interest. And as I mentioned, everything will be available on the CARE website afterwards. So, before we move on to the actual presentations, I'd like to thank our sponsors. And a number of industry partners have contributed to supporting today's meeting. I'd like to acknowledge Allergan, AbbVie, Janssen, Shire, Ferring, and Takeda for their support of the CARE program. Okay, well, with that, we'll move on to our actual program. And the first topic we're going to cover would be functional gastrointestinal disorders. And who better to present this than Dr. Louis Liu from University of Toronto, now the Chief of Service for University Health Networks Gastroenterology. So, Louis, what's new from functional GI disease?
So, in terms of putting things in the Canadian practice, what I'm going to go through is to go through the navigation guide to talk about some of the key poster and symposium that I think will be helpful to you. And at the end, I will summarize a few poster in the IBS, constipation, and diarrhea. When we look at the symposium through the navigation guide, there's one symposium I think that is worth attending. Is the Evolving Concept in the Treatment of Irritable Bowel Syndrome. It's a 20-minute, 3 talks. It talk about the biotic and probiotic from Pimento, and thereafter there's an interesting session I think Subhash will be very interested to go. It's about diet. It's how do we take empowering and think about what diet will be appropriate for our patient, and Bill Shave talk about that. And at the end, there will be a summary of some of these new medication, whether the patient, when they want to take a pill, there's a number of new medication that are coming down the streamline. Some of those, one of those already available in Canada in Nucleotide, and some of the other may soon be available to us as use, particularly Eluxadoline that is already approved by FDA in the state. Regarding the poster, I organized it in your navigation guide for the constipation and diarrhea and some miscellaneous. From the constipation part, the first one is our homegrown Canadian perspective. I present the summary and a brief discussion in the DDW. We put all the data together and put a poster for the ACG, and with some of our care faculty, we put together a practice algorithm in managing chronic constipation. I will present this one a bit more in detail later in this session. The second one is related to looking at how and what effective it is when we're looking at these pooled data in an nucleotide study in how confident and predictable these medication from the patient's perspective, and how, and at the end then generate how the patient think that is more satisfying treating to them, the treatment to us. It is small. The it's a challenge of my eyesight in here. The last two will be for you to explore. I will summarize the first two. The last one will be a systematic review of comparing the nucleotide and one of the newer agent that is on the phase 3 trial now. It's not available in Canada. It's Plecanatide. It's also a uroglycinate analog that works similarly to the nucleotide, and the data is quite similar, so you can visit the poster. And the last one is on lubiprostone on opioid-induced constipation. It is not yet available in Canada, but may soon be available to us soon, so it's worth visiting and seeing the outcome. For the IBS-D, one of the new medication that has just been approved in FDA is Eluxadoline. I'm going to summarize those two first two posters for you in the later part of the talk. The two phase 3 trials already presented in DDW, and the final manuscript is very soon be published. These two abstracts looking at a smaller subset, looking at the subgroup, whether there is certain subgroup that work better than the other, and whether it is improve other abdominal symptoms other than abdominal pain. So I summarize these two for you later. And the last one is for you to explore that, looking at the adverse event that I cover briefly in the second poster, and that looking at a little bit more long terms in terms of where the adverse event occur. And the poster described that looking at all these data together, most of the adverse events occur within the first month or two. Thereafter is quite unlikely, and highlight some of those for you later. For the other IBS poster, the two group that I put together, one of which is related to a newer unique delivering mechanism of peppermint oil. If you look at the ACG guideline in management of patient with irritable bowel syndrome, peppermint oil is considered as a muscle relaxant, that it would help overall manage a patient with abdominal symptoms. These two posters looking at the overall improvement of IBS symptom in this unique delivery mechanism of peppermint oil, because one of the challenge of giving adequate amount of peppermint oil to have the significant improvement in symptom is tolerability. So in DDW, a couple posters were presented. The trade name of that is IBGAST. So these two are the exact additional study, the first one and the last one, looking at this deliverance mechanism, how it improved visceral sensory symptom in patient with irritable bowel syndrome. The middle two talking about the bacterial overgrowth and looking at the role of microbiota in the pathogenesis of the symptom of patient with irritable bowel syndrome. The third one looking at whether the bacterial overgrowth and the amount of bacteria, looking at nucleotide imaging study, that indeed they show that the small bowel, the bacterial overgrowth is indeed from the small intestine, correlate to the nuclear transit study. So that's what I put together in the navigation guide for you in the meeting. You're welcome to go explore. I'll be around. If you're interested, catch me, we can chat. Now let's look at the first ones about our homegrown care Canadian perspective study. It is a national survey that it was sent out earlier this year. It was sent out by the CARE group to a list of physicians that have the interest of practice guideline. If you see the authors are part of our CARE faculty that put this abstract together. Yvonne will be the presenter for the abstract. It is a 9-item questionnaire. Of course, we want to ask many questions, but we have to succinctly concise the number of questions so that the response rate will be as much as we can get. In this case, will be 16%. We have about 55 respondents. The purpose of that is to evaluate how do we perceive with all these available agents that for us to use, how we use it, and which one that we feel it will be satisfying in treating our patient. Therefore, help us to put the evidence that available to us from these guidelines into a practice algorithm if it is indeed necessary based on the need assessment from this survey. So I'd like to highlight a few answers to these questions, and then you can explore the full poster on Monday during the poster session. The couple questions that we ask is that, interestingly enough, when we ask people, the responder, whether you yourself follow an algorithm, a plan, a strategy in managing these patients, yes, they all feel that they follow a stepwise graduated approach, but they don't think that people, when they refer the patient to them, is following the similar approach. So it appears that there may be some discordance in terms of knowledge, and or that there is a need to provide educations to deliver to the referral MDs so that we can bridge the gaps of differences. The second is that when we ask if they feel that the treatment is not satisfying for whatever agent they're using, how likely it is that they will be comfortable to switch it over to prescribed medications. And the referral doctor, the responding MD and also the physician and the patient both feel that they are not very likely, that about 60% of those will be somewhat hesitant to switch over to prescribed medication, either because they think that it's not as effective or because of its side effect or there's some other option. Looking at how satisfying it is for them to perceive when they give these medications, to ask them in managing these patients, the CIC is on the left and then the IBS-C is on the right, that when we look at asking in terms of stimulant laxative, stool softener, osmotic laxative, prokinetic fiber, and prosecretory, this will be the GCC agonist, that when we ask them, when you use these agents, how satisfied it is do you think that your patient would be when you're managing them and prescribe that? It is quite overwhelmingly interesting enough. It doesn't matter whether it's CIC or IBS-C, the level of satisfaction appeared to be higher as compared to all the other agents that the respondents pick. It's ranged at 77% and 80%. Among all the symptoms that these patients experience, what do they think that most affecting their quality of life? Not too surprisingly, it's also very challenging to us, is abdominal pain and bloating. So when we think about an agent that of choice and put it together, we would like to something that able to both managing the bowel movement frequency as well as these abdominal symptoms. So now that the ACG guideline is very well written, it's a lot of work, it's very well documented and summarized and graded all the evidence and the level of recommendation to us. And then when we ask them that how useful do you think these guideline is when you use it to look after your patients, that they think that is about 50-50. Because if you look at somewhat useful or very useful, so only about 50% of those responders will think that it is useful in help them prioritizing which agent to use. And then, not too surprisingly, about 70% of these responders think that adapting the AGA guideline in a more practice algorithm and algorithmic approach rather than a list of items with level of evidence and the grade recommendations will be practical for them. So during DDW, we also together we talk. These are some of the contributing faculty put together this algorithm. It is an adaptation and extension of something that sent out a couple years ago, with the new edition focusing on the results and the outcomes of the questionnaire that was generated based on the responder output in terms of its response to using a prosecretory agent. So we thought that after we look at the history, physical examinations, as well as looking at the diet, looking at the exercise, make sure that we set the target. If those patients who have both bowel movements, frequency challenges and stool consistency, as well as significant functional abdominal symptoms because of its dual mechanism of action and clinical outcome data suggesting improving in those, prosecutory agent was put earlier in the treatment algorithm, particularly for patients with irritable bowel syndrome and with constipation predominant. This is now being putting together with the working group and publishing it in the near future. The second poster that I like to summarize it is related to an interesting concept of that we as gastroenterologists, I always tell my resident and myself that we can always make someone poop. That's not a challenge. The challenge is making them poop in a confident and predictable manner. Otherwise, then they will take a medication. They need to sit at home for the whole day waiting for it to happen and cannot go out or do anything. So the patient frequently come back to tell us that I don't know whether I can plan my day. I don't know what to do. So this is a very interesting way of looking at it, that in order for the patient to feel that a treatment is satisfying, they need to feel confident it generates result, and as well as generate results in a predictable manner. So that's why I think it's a very interesting study looking in that particular patient perspective of how that helped them to manage the symptom. It is a retrospective review looking back to the phase 3B trial looking at a patient with constipation. In that study looking at particular bloating and comparing, comparing that to the prior constipation medications now using linaclotide in compared to some of the other agents that they have used in the past in answering three specific outcomes. One is how confident that you would feel that you're able to have a bowel movement every other day, basically 3 bowel movements, roughly 3 bowel movements per week or more. And the second is predictable having bowel. When do you predict to have a bowel movement after taking medication? Meaning that you don't need to stuck at home for the whole day or don't know whether you can go out tonight or wait until the next day. And how satisfying it is overall in relieving your abdominal symptoms. And if you look at the overall result, they have a forest plot in the poster, and but it's just too much to go through it in detail. But in general, that depending on the dosage, depending on which agent you compare, the linaclotide appear to be effective and better than some of the other agents this patient population has used in the past in producing a more predictable and confident output that for them it rates highly satisfying. So I think that it will be interesting to go talk to the author and look at the full poster and get more details. Now I'd like to switch over after constipation. We would like to switch over diarrhea. I put 3 posters in your navigation guide. The first one is on the Eluxadoline. Eluxadoline is, for those who are not familiar, it is a mixed opioid agonist and antagonist. It has 2 agonist actions on the mu and kappa, and it's a delta antagonist. It is locally active, and it has 2 phase 3 trials that already completed and presented in DDW, looking at its efficacy and safety in treatment in patients with irritable bowel syndrome with diarrhea predominant. So what this is the primary endpoint. It is a combined FDA endpoint looking at 12-week 30% reduction of the worst abdominal pain and Bristol stool 4 or higher, that little banana smooth shape or a stool in the Bristol stool chart or higher consistency and 50% of the time during the study duration. If you look at it, it's statistically significant across both treatment dosage, 75 milligram or 100 milligram twice a day. So we already know that it's already shown in these phase 3, the 2 phase 3 trial is effective. What this one is looking at is that if there any particular subgroup If you look at some of the other agents that previously using in treating patients with constipation, that there may be a male and female gender difference. So this look at both the sex in male or female if it's different. We're also looking at whether younger and older patient population is different or any other associated comorbidity, in particular related to depression or patient of cholecystectomy. I'll go a little bit more in detail why cholecystectomy at the end, and also looking at patients with different level of abdominal pain. The abdominal pain is a 0 to 10 severity score. They look at less than 5, between 5 to 8, or over 8, which is very severe. So looking at all these different spectrum, subgroup, and see if there's any of these subgroup will be more effective or the other. As an overall generalized statement, it appears to have no difference depending on which subgroup you look at. It is effective in all subpopulation that they look at. Don't go into detail of the number, but just look at the trend of the responder column, that in the placebo line and the treatment 75 versus 100 milligram twice a day, it's very similar. The percentage is very similar, meaning that to me that when I'm treating a patient that is either male or female, less than or over 65 are very similar. Over 65, the absolute number seems to be higher. Is 36 and 40. 46%, 35 and 46% compared to other, but it's a small number of patients and there's no statistical analysis between those groups. But compared to placebo, it is significant. When we look at the other comorbidity in terms of depression, reflux on cholecystectomy, and there is no significant difference. And you also look at the absolute percentage changes is very similar. The question to me was interesting why they look at cholecystectomy. It doesn't look very obvious, but it is obvious that now when we look at the adverse event. When we look at the phase 3 trial, the adverse events of Eluxadoline, not too surprisingly constipation because it's using for diarrhea predominant IBS, but it's also because of biliary pain and sphincter dysfunction type pain. In all those patients, that is, majority of those occur in the first dose, and all the other will occur all within a month. The question is that for those patients who have cholecystectomy in the past, do they respond differently in this subgroup? So that addressed that despite that have or have not whether the patient has cholecystectomy, the treatment outcome is still the same. It doesn't address the specific event related to these chronic constipation, but it seems to be as a group when we pick this patient for treatment, despite that they have cholecystectomy in the right patient population, it will still be efficacious. The second one, looking at the other abdominal symptoms, we talk about that in the phase 3 trial. It looked at a combined outcome of abdominal pain and stool consistency improvement. We already look at some of the other associated abdominal symptoms in patients with irritable bowel syndrome. Is more than abdominal pain. Bloating is also another burdensome symptoms. So this particular study, a poster looking at the 2 phase 3 clinical trial looking at these patients who report on a electronic diary if any of these other abdominal symptoms, looking at abdominal general abdominal discomfort and bloating in a 0 to 10 scale, looking at urgency and fecal incontinence over 26 weeks to see if any of these symptoms are significantly improved. Again, there's a long table that in the abstract that you can go see, but it's a executive summary that it appeared to be significantly improved in other general abdominal discomfort, particular bloating in this case, and also reduce bowel movement frequency and urgency associated, and as well as the associated incontinence. If you actually look at the number, the absolute change in number is not very high. It's usually 1 or maybe 2. The question is clinical significance versus statistical significance. There's no doubt that it's statistically significant based on the analysis. Interestingly, when they look at that through these sustainability, that during the 26-week with these self-reported outcome, they were effective, and the effect was sustained throughout 6 months. This is all I would like to summarize for you, and thank you very much for your attention.
People at home. We have a couple of minutes for questions for Louis. Just a couple of questions. LA?
So the question is that what do I think that some of the individuals, I think you refer to this question, that why about 45% of those were neutral. The way I see that is that if there's a piece of recommendation giving it to you, how useful do you feel it is to help you to prioritize? It gives you a list of evidence. It gives you 10 things that is all high quality, strongly recommended. But among these 10, which one should I pick? So some people may have the ability to, based on the practice experience, to pick which one they would choose first. That could also depending on your clinical experience, familiarity of the medication cost, and all these a number of factors. The neutral to me, they just don't find it helpful and find it not very helpful, and they need a little bit more guidance. That's the way. So Nepal, the question was that the algorithm that we were working on, did it take into consideration the practice differences, United States versus Canada? So if you look at that algorithm is particularly tailored for Canada. So only the agents, therapeutic agent available in Canada and treatment modality available in Canada were listed in the algorithm. You can come to the poster. We can talk more. That algorithm is there.
Well, thanks very much, Louis. I think we should keep moving in the interest of time. So it gives me a great pleasure to introduce our next speaker, who is our newest member of the CARE faculty. He's next generation, not like us old fogies. So it gives you great pleasure to introduce Niraj Naruj. Niraj graduated from our fellowship program last year, and then has been doing an advanced IBD fellowship at Mount Sinai Hospital in New York, and has completed that fellowship, and if all goes well, he should be joining us at McMaster very soon on faculty.
Thank you for the introduction, John, and I'd like to give thanks to the CARE organizers for having me come to speak today. I'll be speaking to you about the highlights of Crohn's disease abstracts at ACG this year, as well as maybe highlights of Crohn's disease this year period. So there's a couple of key updates that came out this year in Crohn's disease that I think are very important for all gastroenterologists to be very well versed with, including some updates in post-operative prophylaxis of Crohn's disease, as well as a new molecule that I think is very promising for treatment of Crohn's disease, and I'll discuss those with you briefly. And then we'll go over some of the hot abstracts here, including the Unity 2 study, which is a phase 3 study looking at Ustekinumab in Crohn's disease, outcomes of temporary fecal diversion for refractory Crohn's disease, a new novel serum biomarker, serum Amyloid A, and how it may be potentially useful in inflammatory bowel disease, as well as a poster that I thought was quite interesting looking at outcomes of IBD patients with CMV infection and their outcomes. So the first study that was published this year that I thought would be relevant and important for everyone to know about is a POKER study. This was published in The Lancet earlier this year by Michael Kam's group from Australia. And essentially, this is a very interesting post-operative study. The conventional post-operative Crohn's disease study that we see is treatment versus placebo. And as a result, there's a whole bunch of treatments that look like they're effective for Crohn's disease, but really no one knows how to use them and when to use them. And the reason why this is a very interesting study is because they looked at actually a post-operative algorithm for treatment of Crohn's disease and randomized patients to different algorithms to decide on how to manage these patients. You see, after patients had surgery, they essentially were risk stratified into low or high risk. Patients considered high risk are those who had prior resection, those who are smokers, or those who have evidence of prior penetrating disease. And essentially, these patients got randomized either into conventional no endoscopy strategy. They got put on a drug and then were basically seen at 18 months with a follow-up colonoscopy. Or they got put into an arm where they had an endoscopic intervention at 6 months, were assessed based on any evidence of endoscopic recurrence. And then if there was recurrence, they'd be escalated on their treatment, and then they'd be seen again at 18 months. All patients were given 3 months of flagyl. And then if you were considered a high-risk patient, you would also be given the thiopurine. Unless you previously were thiopurine intolerant, then you would be put on adalimumab. I thought it was interesting that even people who had been previously on anti-TNF, they would still be put on thiopurine if they were considered a high-risk patient, unless they had prior thiopurine intolerance. So looking at some of the results from this study, we see that at 18 months, those who are in the standard care arm actually had evidence, a larger number of them had evidence of endoscopic recurrence compared to those who were in the active arm or the group receiving endoscopy at 6 months. And then also looking at the record scores, you can see there's a higher score distribution in those who, again, were in the standard care arm versus those who were in the active care arm. I should mention, I don't think I actually mentioned this, at that 6-month period, if there was evidence of recurrence, defined as I2 or higher, their treatment would be stepped up. So if you were on a thiopurine, for instance, you'd be stepped up to adalimumab. If you were already on adalimumab every other week, you'd be stepped up to weekly therapy. This I thought was also a very interesting result that they had published. And they looked at all the patients who essentially got put on post-operative adalimumab immediately, and then also compared them with those who got put on thiopurines, had evidence of recurrence, and were escalated to adalimumab plus thiopurine. And at 18 months, actually, the recurrence rates were similar in both of those groups. Another study that was presented at DDW this year is also an important post-operative study. It was a PREVENT study. And this is a follow-up study from Miguel Verguero's post-operative Infliximab study that was published a few years ago. And I think this is actually very interesting because of the result, which was actually negative, and I think that was very surprising to a lot of people. The initial study that some of you may recall was looking at roughly 10 patients in each arm, and there was substantial improvements in the Infliximab group in terms of post-operative recurrence. But this study, what they did is they looked at essentially clinical recurrence at roughly 76 weeks, 150 patients roughly in each arm, Infliximab or placebo, and they actually found that there was no significant difference in clinical recurrence at 76 weeks, as well as 104 weeks. The main issue being a couple things. One is the clinical recurrence was defined as a composite outcome of endpoint of increase in CDAI, as well as endoscopic recurrence and or fistulizing disease. There was also some issues in how they powered this study, and they may have underpowered it based on how they thought the amounts of post-operative recurrence rates would end up being compared to what they ended up being. Interestingly enough, and probably not surprising, in the endoscopic recurrence arm itself, we do see substantial improvements in terms of reduction in endoscopic recurrence in the Infliximab group compared to those receiving placebo. But certainly it'll be interesting to see when this does get published why this ended up being ultimately a negative study. So some of the take-home points in post-operative Crohn's disease, like I mentioned, previous studies have focused on one active drug versus placebo, and POCR is unique as it gives us a post-operative algorithm for high-risk patients, and quite frankly, we can see that you can now selectively use potent immune suppression and adjust it as needed on the basis of colonoscopy as likely a method of having effective disease control for most patients.
So I read the Australian study.
Yeah.
What was the dose of metronidazole from 0 to 3 months, and what was the rationale to put all patients on metronidazole?
So the dose was 400 milligrams BID, and the rationale is because we do have a couple of studies which are now more than a decade old that have shown that using these therapies for 3 months in the post-operative setting does have a reduction in clinical and endoscopic recurrence for Crohn's disease. It's reasonably good data. The main issue is that the previous studies find that this is very not tolerable for patients. A lot of patients end up developing adverse events from this, and practically we also find the same. So it doesn't get implemented too much in clinical practice, I find, but there is data for it, and it is even recommended in some of the post-operative reviews that suggest how you should be managing post-operative Crohn's disease.
So yeah, in the POCR study, can you just go back to the slide that showed what they did with the patients? Because in the, that one. So in the endoscopic intervention group, were they on nothing for 6 months, and then they'd scope them, and then they'd make a decision? So
the patients who were low risk, they would have got 3 months of flagyl, and then they would be on nothing, and they would get scoped at 6 months. The patients who were high risk, they would have got the 3 months of flagyl as well as 6 months of thiopurine, and then had that scope, and then if they had recurrence, they would be escalated with the addition of adalimumab on top of the thiopurine. Right, depending on what you were on previously. Okay, so this was published in the New England in March of this year. This is from Italy, from Monteleone's group, looking at a molecule called mongersin. Mongersin essentially blocks SMAD7, and we know that high levels of SMAD7 can lead to low levels of TGF-beta1, and low levels of TGF-beta1 are implicated in the inflammatory pathway seen in Crohn's disease. This essentially was an oral molecule that you consume once a day. They essentially randomized patients to one of 4 arms, placebo, or one of 3 different doses of Mongersen. And they only gave them this for 2 weeks, and then they looked at their outcomes at 2 weeks, which was clinical remission as their primary endpoint. And you can see there that the rates in the 40 milligram per day and 160 milligram per day are, quite frankly, some of the highest we've actually ever seen in Crohn's disease studies. And this is actually only after 2 weeks of therapy. They mainly actually only enrolled either steroid refractory or immunomodulator refractory patients, and not looking at biologic refractory patients. And what they did after that 2 weeks is these patients went off therapy, and they looked at them a couple weeks later, and they still found that the clinical response rates were substantially higher in these patients who were receiving the higher doses of Mongersen. Adverse events were also, it seems like it's very safe, and you can see that most of these adverse events that are recorded are actually probably just worsening of the patient's Crohn's disease and not actually adverse events. And it seems like the adverse event rate was pretty similar in all of the groups. This study is this drug seems very promising, and right now they're undergoing phase 2b study where they're looking at endoscopic intervention as well and seeing if this also leads to endoscopic healing. And I think the message from this is that it seems like there's some very effective meds in the pipeline, so don't lose faith yet. So now getting to some of the abstracts that will be presented at this meeting. This is one of them that I think is a very important abstract that will be presented by Brian Fagan on Tuesday. And essentially this is the phase 3 study looking at Ustekinumab treatment in Crohn's disease. Interestingly enough, they're looking at patients who are naive or not refractory to anti-TNF. And this is a little bit different than the study that was previously published in the New England, the phase 2b study. So just to give you a quick background, this study that was published in 2012, I believe, essentially was looking at patients who were previous anti-TNF refractory patients. And the reason they looked at that in their phase 2b study was because the phase 2a study suggested that was the population that there might be some effect on. And they didn't actually find in the patients who were not TNF failures that the drug was working that greatly. So I thought it was very interesting that in their phase 3 study, that's the patient population that they decided to focus on. Now, the results that we saw from that New England paper was that after receiving 1 dose by IV at week 0, at week 4, there was significant improvement in the clinical remission and response rates in the group that was receiving Ustekinumab, and that response seemed to persist out to week 6 and week 8. And as a result, some of us as practitioners in Canada like to use this drug for patients who are anti-TNF failures off-label, since we have access since it's approved for other indications in Canada. This phase 3 study is looking at a large number of patients, 628 patients who have moderate to severe Crohn's disease, who have prior steroid or immunomodulator failures, but not anti-TNF failures. Now, that said, they can be on anti-TNF therapy, and a large portion of them were on anti-TNF therapies, but they weren't failures to these. And they were randomized either to placebo, a fixed dose of Ustekinumab, or 6 milligram per kilogram IV, and their primary endpoint was a week 6 clinical response. And we see that in both Ustekinumab groups, the week 6 clinical response rates were significantly higher than those receiving placebo, as well as the week 8 clinical remission. Like as I mentioned, more than 30% of these patients were previously exposed to anti-TNF medications, and in some of their secondary outcomes, they did find substantial improvements in some of the objective things that we'd like to see, including reduction in CRP, fecal calprotectin, as well as some clinical disease and indices.
Is that a typo in your dosing there? Because it says 130 milligrams versus 6 milligrams.
No, it's not a typo. One was a test of a fixed dose, and one was per kilogram type dose. I'll go back here. So you see here that they tried 3 arms, 3 doses, and the highest dose that they had tried there was 6 milligram per kilogram as well.
It's a huge dose difference, but I guess okay.
Yeah, it's
400 versus 130. Okay, but
it could quite frankly be a huge dose difference, and for some of these things, dose does matter. So that's why I think part of the importance in studying that. Looking at safety outcomes, it seems like there was no increase in adverse events in those receiving Ustekinumab, and no serious adverse events were experienced by those being treated with Ustekinumab. And their conclusion is that IV Ustekinumab does induce clinical response and remission and seems to be well tolerated. So some of the outstanding questions I have from just looking at that, and things I'll be looking to see if they answer when they present this, is why that they did not find an impact of Ustekinumab in the anti-TNF naive in the phase 2 study that they previously had done. And then we'll be looking to see some of these things down the line, including its response on endoscopic healing. We're still awaiting maintenance study results, IM immunity, and we'll obviously hope that it's effective in maintenance as well before we decide that we want to use this drug. And some phase 4 studies probably down the line will be looking at things like fistula closure exposure and immunogenicity of this medication. Impact on Canadian practice. I think currently some of us are using this off-label for the anti-TNF refractory patients, and I would continue to do so based on these results. The next abstract I'll discuss with you is looking at serum amyloid A as a novel serum biomarker for patients with IBD. This will be presented by a group out of University of Miami. And essentially some background on this is we know that biomarkers for disease activity like CRP and fecal calprotectin can be potentially useful for us, provide us a cheaper and non-invasive method of assessing patients with inflammatory bowel disease. However, CRP does not seem to correlate well with mucosal inflammation, and up to 20% of people don't actually produce it. So in that patient population, it's quite tough. So this study aims to assess actually several serum biomarkers, including serum amyloid A as a potential biomarker for IBD. This was cross-sectional in nature, and they looked at essentially Crohn's disease and ulcerative colitis patients who were undergoing colonoscopy, and then at one time measured all these different serum biomarkers, including CRP and serum amyloid A. And in the results, we see that serum amyloid A actually predicted inflammation better than any of the other serum biomarkers, including CRP, and is the case for both isolated small bowel disease as well as colonic disease, which may give it some utility compared to calprotectin, which does not seem to be as good for isolated small bowel disease. That's quoted there is a receiver-operated characteristic of 0.8, which is the area under the curve. And for those people who may not be familiar with that, 0.8 is actually considered a pretty good value, pretty good result for area under the curve for a diagnostic test. And they actually did a nice subgroup analysis in those who had normal CRPs, and you can see that, for instance, in that second line there, 16 patients who had normal CRP but evidence of macroscopic inflammation, more than 80% of them still had elevated serum amyloid A, so it is a potentially useful marker, especially in those who do have normal CRP. What are the limitations? Well, this is just a cross-sectional study. That means it's a one-time value in looking at people who have evidence of inflammation at one time. And really we'll need some longitudinal studies to examine how this responds. Does it go down with treatment? It's actually available in Guelph if you are a cow, and you can get it done. But it doesn't seem to be available for humans quite yet, but hopefully soon, depending on what it can potentially be useful for. So next abstract I'll be presenting, we'll be looking at outcomes of temporary fecal diversion for colonic and or perianal Crohn's disease. And some background on this is that some clinicians will resort to temporary fecal diversion for people who have refractory colonic or perianal disease. And we have this belief that diverting the fecal stream will give us some time to allow medical therapy to start working and maybe improve their disease before we take down that ileostomy, and hopefully that way they can get under a little bit better control. This was a retrospective chart review period, and over that 10-year period, they had found 30 patients who underwent temporary fecal diversion. We see that about 37% of them had it for perianal Crohn's only, and a large number of those were people with complex fistulizing disease, and most of those patients had failed prior biologic therapies before undergoing ileostomy. 12 of these patients attempted ileostomy reversal, and 6 of them ended up having failure of that, including requiring eventual colectomy and end ileostomy, and the rest of them remained diverted because of persistent disease, and they just didn't think that they would even be able to go back because of how bad their disease was. And predictors of remaining diverted were people who had evidence of complex fistula, had prior number of interventions for their fistulizing disease, or were on chronic narcotics. So conclusions from this study were that 80% of patients who underwent of post-operative medical therapy diverted or require colectomy within 2 years of having an ileostomy. I think impact on our practice is that really we should know that outcomes after temporary fecal diversion are quite poor, and when we are counseling our patients, an attempt at having a temporary fecal diversion, we should maybe stress that this may not be temporary. The last abstract that I'm going to discuss with you is a poster that will be presented on Monday from the Cedars-Sinai group, and it's looking at outcomes of patients who were treated after having a CMV infection identified. Some background on this is that we know that IBD patients do have an increased risk of CMV colitis because some of the immunomodulators and anti-TNF medications that we're using, and sometimes this may be incidentally identified on mucosal biopsies, and it's not clear if we need to be treating the CMV infection in all of these patients. This was a retrospective study where they looked at all IBD patients who had CMV identified on pathology, and then they essentially found that their median number was 5, and they classified them as high or low grade infection based on that median number. And when we look at these outcomes here, we see in the group that was considered high grade infection, those who were treated versus those who were untreated, really the outcomes were pretty similar. Length of stay in hospital, hospitalization rates. CMV PCR was obviously a lot higher for those, well, maybe not obvious, but it was a lot higher for those people who they ended up treating. And we see actually the colectomy rates are slightly lower, not significantly so, but are slightly lower in those who were treated versus those who were not treated, who were considered a high-grade CMV infection. You look at those with low-grade infection, really all the outcomes were pretty similar, whether they were treated or not treated, including colectomy rates. So conclusions from them were that treating patients with high CMV burden may lead to improvement in colectomy rates. I'm not sure if I would make that conclusion yet, but some of the things I would take away from this are that, one, anytime you're dealing with the active IBD patient, you should always ask your pathologist to rule out CMV infection. And two, is that those who have low-grade infection, for them, antivirals are unlikely to be beneficial, and you should be focusing on treating the disease itself as opposed to worrying about the antiviral. So some of my take-home points, using colonoscopy to assess the post-operative Crohn's disease patient is a good way to decide whether they need to have escalation of therapy. Mongersen seems like a promising molecule in the pipeline. Ustekinumab seems effective for anti-TNF naive Crohn's disease patients. Serum amyloid A may be a useful biomarker for IBD. Temporary fecal diversion is often not temporary. And CMV does not need to be treated with antivirals, probably when it's a low-grade infection. And that's it. Okay, the question was the role of CMV and whether this is always limited to the colon or if it's sometimes found systemically, including in the blood. Certainly, sometimes it is found systemically, and if you did a serum PCR, you could find elevated levels, and that's certainly to be the case more often when you have a high-grade infection in the colon as well. I'm not aware of studies where they're looking for CMV elsewhere, like for instance in TI biopsies and so on, and most of the stuff I've read has always been colonic disease. And the current ECHO guidelines are suggesting that use of PCR should be used as as something that can help you decide whether you should be treating this or not. But at this time, it's based on very poor data. We don't really have great data to support how we should be managing these patients.
PCR of colonic tissue or PCR?
PCR of colonic tissue. Right. The study was, would I use fixed-dose ustekinumab for treatment of Crohn's disease? Well, currently the option to us in Canada is subcutaneous. First of all, these are IV doses. And the second is that when it's a subcutaneous, it comes in a fixed-dose pen. So you can either get 45 milligrams or 90 milligrams. So right now we don't have too much choices, but when it's approved in Canada, I would use IV based on that being what's being studied for Crohn's disease.
Okay, great. Well, thanks very much, Niraj. Great presentation. We've got to try to keep to time, and we'll move on. Our next thanks very much. Our next speaker is Dr. Bitton, who's going to speak to us about ulcerative colitis. Dr. Bitton is chief of GI at McGill University, familiar to all of us. Got some nice, pretty pictures of Honolulu to show us, I think.
That's right.
Great.
I was thinking of going to those places. So my task was to look over ulcerative colitis at the ACG. So in terms of drug development in ulcerative colitis, it hasn't been as exciting as in Crohn's disease, but there's fairly some interesting abstracts that have been presented here that I'll go over. So there's some talk on mucosal healing, which I'll discuss. There are some abstracts on medical therapy, revisiting antibiotic use, anti-TNF, more data on vedolizumab, and there's not that much on newer agents apart from one oral agent, which I'll review. And then there's a very interesting study, a Canadian study looking at healthcare costs related to IBD. So if you look at the abstract on mucosal healing, this is a study from the Mount Sinai group in New York looking at long-term outcomes in ulcerative colitis after early mucosal healing. So basically, this is a study that looked at a meta-analysis that looked at several studies, over 14 studies, where they had endoscopic data at early on, usually potentially 3 months, and later on remission data at 1 year or beyond. And basically what they showed was that in these studies, overall, patients who achieved mucosal healing early on in the course had a much better outcome and had long-term remission rates, clinical remission rates with an odds ratio of close to 5. And it didn't really depend on how you achieved endoscopic healing. So you know that sometimes we're faced with patients, when we do colonoscopies, we see carpets of pseudopolyps, and we figure out how are we going to survey these patients and what's the risk of dysplasia in these patients. So this is a retrospective chart review of patients undergoing surveillance colonoscopy over a 10-year period. And they looked at and identified patients who had pseudopolyposis based on endoscopic and pathology criteria. And this is a case-controlled study, so they matched patients with pseudopolyposis, those without pseudopolyposis, with various factors. And basically on a multivariate analysis, the presence of pseudopolyposis was increased with a over twofold risk of developing future dysplasia or colorectal cancer. That's meaningful. The only big problem with this study is that they didn't account for one major factor, which was disease activity, because we know that inflammation is a driver of increased risk of dysplasia. So that wasn't there. So that could be a potential issue. But nonetheless, it gives us a thought, thought-provoking about pseudopolyps and how we should actually survey these. So in terms of medical therapy, the question of antibiotics has again been revisited. Antibiotic use in acute ulcerative colitis and induction of remission. So they looked in this meta-analysis at all studies that had placebo versus a variety of antibiotics in their capacity of inducing remission. So there's a study with vancomycin, metronidazole, Tobra, Cipro. And basically, when they did their meta-analysis, there was really no net effect of antibiotic use in acute ulcerative colitis. Now, one could argue that a lot of these studies may be underpowered or not good quality, but nonetheless, there is no real big signal with antibiotic use in ulcerative colitis. And I think our guidelines don't really actually make discussion of antibiotics as primary therapy for UC. So there's no head-to-head studies looking at anti-TNF agents in ulcerative colitis. There was this study here, which is a real-world experience, and I'll define to you what they meant by that. So this is a retrospective study looking at moderate to severe ulcerative colitis patients over a 2-year span. These were patients who were anti-TNF naive, and then they looked at what they called real-world effectiveness. I guess this is what translates when we're in clinic. And they looked at symptoms and disease activity, which they characterized using partial Mayo scores. And they basically looked at patients treated with adalimumab and infliximab. They characterized them as moderate or as severe. And basically just to show you that in terms of symptoms, rectal bleeding and increased stool frequency, or partial Mayo score, there was really no difference. And there was no difference in time to remission between infliximab and adalimumab group for moderate UC or severe. So basically showing similar study. Now this is not a randomized controlled head-to-head study, but this was fairly interesting numbers and well-characterized patients. So the other study that came out is this one that's going to be presented by Dr. Fagan on Tuesday's plenary session, in the IBD session in the morning, looking at vedolizumab and the role of concomitant immunosuppressants. So, you know, there's been a lot of discussion and a lot of bit of shifting. Should we go with concomitant therapy and anti-TNF or not? So this is a glimpse of some data looking at the maintenance of vedolizumab. So this is a post hoc analysis from the Gemini 1 study, which is the ulcerative colitis study. This abstract also had the Crohn's disease data, but I just extracted the UC data, given John asked me just to do UC, right, John? So just want to be consistent. So this, if you recall the Gemini study, it's 6-week responders were then randomized to placebo versus vedolizumab every 4 weeks or vedolizumab every 8 weeks over a 52-week period. And you know, it's quite interesting here, but the group of patients who are on immunosuppressants, after 6 weeks, those who in responders, those who were in the United States, their immunosuppressants were discontinued, and those who were outside the United States, it was continued. So that's how they characterize their groups. I don't know why they chose US and non-US, something FDA or yeah, probably. So, so when they looked at then efficacy endpoints in terms of clinical remission and clinical response, so of course versus placebo, these both with and without concomitant steroid immunosuppressants were superior. But when you compare concomitant immunosuppressants versus no concomitant immunosuppressants, there was no difference. When you look at immunogenicity, very little numbers, so it's hard to make any draw any conclusion. But what you do see is that there's very little immunogenicity, at least in this patient cohort. And then when you look at trough levels, again, there was no difference whether you were on concurrent immunosuppressants or not. So there's a suggestion here, although this is a post hoc analysis, that the use of concomitant immunosuppressants with vedolizumab may not add additional benefit. But again, this is again a post hoc analysis, and there needs to be more studies. Vedolizumab, as you know, in the US has been approved for a longer time than in Canada. So there is this study, but a multi-center consortium that was created in the US looking at active IBD. This group here wanted to quantify treatment effect in clinical practice. They had multiple sites with ulcerative colitis and Crohn's disease. And in general, patients with ulcerative colitis had higher response rates, remission rates, and mucosal healing compared to Crohn's disease. But I'm showing you again, once again, just the data extracted for UC. So for ulcerative colitis, they had moderate to severe active patients within 4 weeks of starting vedolizumab. They had very good endoscopic and clinical follow-up, so it amounted for 59 patients. And what you see over a 12 to 26 to 30-week period, you see a cumulative response, remission, and mucosal healing rate that increases in quite interesting numbers, up to 73% of patients at 30 weeks responding and 50% being in remission. So this is quite interesting. But again, this is not randomized control. This is open label following up of a cohort. So you are all aware of the UC guidelines that were published recently, the Canadian consensus guidelines. There are a lot of guidelines out there, and this was a poster I thought was interesting because it was another form of guidelines, but it was really focused on positioning treatments for ulcerative colitis. So where do you put your treatments in the algorithm of ulcerative colitis? And they used a methodology which is called RAND appropriateness methodology, so research and development. And it's to establish appropriateness of treatment positioning in ulcerative colitis. So basically what it does is it combines the best clinical evidence that's out there with clinical judgment of experts who basically deem if a certain statement or an intervention is appropriate. So there's an extensive literature review which was done for mild to moderate UC. So they had 14 world experts in IBD. I don't know how they define world experts, but we'll trust them on that. There were 225 case scenarios rated for appropriateness of UC treatments. And then they had a scale, a graded scale of 1 to 3 being inappropriate, 4 to 6 uncertain, and 7 to 9 being appropriate. Then they used a modified Delphi method, web-based score, and then finally a face-to-face meeting. So they agreed on 224 out of 225 case scenarios. So they just presented in the abstract extracts of the findings. So when they looked at role of surgery, it was considered appropriate when patients failed biologic therapy. It was considered inappropriate when there was mild limited disease. And it was considered uncertain in scenarios where treatment options remained. So if you had done one and failed one anti-TNF, at that point the role of surgery was uncertain. In terms of uncertainty, what was considered uncertain is the addition of thiopurines or steroids when failing biologics, or escalation of vedolizumab in primary non-response or in secondary loss of response. Now, we really don't have the access to increase vedolizumab or dose escalate, but here there's just not enough data. And what was considered appropriate was that anti-TNF or vedolizumab in steroid-dependent patients or in thiopurine-resistant patients. And it was considered appropriate to switch between vedolizumab and anti-TNF in the context of treatment failure. So very similar to what we had in our UC guidelines, but the methodology was slightly different. So the only abstract I could find on novel therapies is this oral medication, ozanimod, which is an oral S1P receptor modulator. And in fact, what this does is by blocking this receptor, it sequesters lymphocytes in lymphoid tissue, so they can't actually get to the sites of inflammation, and so T cells actually get to the site of inflammation. So this is a maintenance trial, and at DDW in May, there was the induction trial that was presented, 197 patients who were treated for 8 weeks, and 103 of these patients achieved clinical response, and then were put in for an additional 24 weeks of maintenance. And the doses that were used were 0.5 milligrams per day, 1 milligram per day, or placebo. And just to show you that when they looked at the endpoints of remission, response, and mucosal healing, both doses were superior to placebo. So this is a potentially interesting medication. It's an oral medication, so not IV sub-Q, so easier of administration. And certainly more studies will come with this agent. And I think it's being used also in multiple sclerosis, or being studied at least. So the final paper I want to present is on healthcare costs in IBD. So this is a paper from the group in Calgary. So I just want to go back a couple of years ago when, with the CCSC, the Burden of IBD in Canada report came out. It was published in the Canadian Journal of Gastro. And at that time, in 2012, it was estimated there was about 230,000 Canadians with inflammatory bowel disease, with an estimate of 10,000 new cases per year. And based on several analysis, they estimated the overall costs in 2012 were $2.8 billion for IBD. There were indirect costs and direct costs. And just the direct cost was, half of the cost was prescription drugs. And what you see is the biologics were substantial percentage of the cost, and that there had been a great surge in biologic use over the previous 4 years, which made up most of the prescription costs. So the group from Calgary here put forth this study where they looked at the rising burden of IBD in North America for the next 10 years. So they have a predictive model. I'm not showing the US data, just the Canadian data, but basically what they did is they reviewed all population-based studies on epidemiology, prevalence, and incidence, and did some modeling, and they actually estimated the evolution of prevalence over the next 10 years, and they reported as annual percentage change of prevalence in the left column. And at the same time, they actually look at costs, and they did, again, very advanced analysis and modeling and cost, looking at the consumer price index and so on. And basically, what you see here is that the prevalence certainly increases over time, and the dominant prevalence increases with Crohn's disease more than ulcerative colitis in their predictive models. And so where a prevalence of total IBD in 2025 would be 887 patients. So it'd be a total of about 350,000 patients afflicted with IBD in Canada. So if you remember, the CCFC paper was 230,000. And if you look at the total cost and the direct cost, so just hospitalization, surgery, medication, it's estimated it's going to be $2.3 billion. So we're talking twice as what it was in 2012. So this is something to be very concerned about, because it's going to, the payers are going to latch onto this, and there's going to be major issues, and we have to figure out ways where we could be more cost effective and try and reduce costs. So I thought that was quite important to sensitize us to this problem. So when we review key news in ulcerative colitis and ACG, the routine use of antibiotics not shown to be effective in ulcerative colitis. Mucosal healing is associated with higher rates of long-term remission. There doesn't seem to be an added benefit, again, but maybe premature, of concomitant immunosuppressants with vedolizumab. And anti-TNF and vedolizumab are positioned same in moderate to severe UC, and pseudopolyposis may be a risk factor for dysplasia. And from a Canadian perspective, really the two key messages, I think, is again, the question of mucosal healing that we keep on going over and over. Should it be our target? And if it is, when should we assess it? Is it at 3 months? Is it at a year? And how will we manage therapy? And what will be the impact on our resources? And then the healthcare costs, which will be increasing over the next 10 years. And it brings us to question, maybe we should be looking, and we are actually looking at quality indicators that include cost effectiveness. Maybe we should be looking at novel methods for healthcare delivery, new prevention strategies, and importantly, personalized medicine. If we find the right drug for the right patient initially in the treatment, that potentially can save costs. So on that note, I'll finish. Thank you very much.
Thanks very much, Alain. That was excellent. We have a couple minutes again for questions. I might ask you, those direct costs, how much of that was increasing prevalence and how much of that was increasing utilization of drugs?
So there's the abstract was very limited in data, so I can't tell you. I suspect the drug use is probably a good portion of it, and but really, the data itself, there was just not enough.
Take the whole budget though, direct and indirect. It's not the argument that better treatment of mucosal healing should be able to shift from one to the other and not change in the envelope. If you make that argument, then you've got the argument.
The argument that if we go,
Use the envelope.
yeah,
28 billion. You're not using more money. You're just shifting it within.
yes. So that would be a possibility. But the issue that comes out is, for example, if you're talking about mucosal healing itself, to achieve that, the question is the cost to achieve mucosal healing, would that overcome or counterbalance, the savings?
The employment and the tax revenue.
Yeah.
Like you're turning that volcano into that lush paradise with therapy. That's what you're doing. Niraj?
I don't know if they had discussed it in their abstract.
Yeah, so this was more a comment. Thank you. The comment was that although there may be increased direct costs, there may be a reduction in indirect costs, and so that might balance the budget.
Thank you. Okay, thank you, Alain. We're going to keep moving, and the next topic is upper GI disorders, and we have the master of the foregut with us, Dr. David Armstrong, who is going to tell us what's new in the foregut at ACG. Thanks, David.
Thank you very much. Master of the foregut. That's superhero. Not. I'm going to, if nothing else, I've got to work out how to put this on. So, firstly, thank you very much for asking me to speak about upper GI disorders. I had looked through the abstract. Does anybody know who this is? Is that you? Give me a year or two. So I'll go through. I hadn't realized who's in these films. No. So he was actually in Dr. Strangelove, he was in Blazing Saddles, and this actually is Louis Burton Lindley. Why did I pick him? Because when I looked through the abstract, I thought they were pretty slim pickings. So I'm going to talk a bit about gastroesophageal reflux disease, a bit about Barrett's, which I sort of separated out from gastroesophageal reflux disease, and then gastric intestinal metaplasia. And I would concentrate on Hawaii rather than any of those, but you're stuck with me, so I'll talk about this for the next 15 minutes. Where are we going to go? So key news. One of the ones I'm going to address is which appears to be the recurring theme of PPI complications. I'm going to put a plug in for the WGO, World Gastroenterology Organization, global guidelines. There have been guidelines which I think are worth referring to. They are worth referring to and having a look at from an international group, the so-called Bobcat guidelines about the management of Barrett's. In the absence of dysplasia, there is an AGA quality guidelines coming out in the next couple of months. It's actually online, but is not yet in full print format. And then there really isn't much about gastric intestinal metaplasia, but I thought I'd address that anyway. So there's some key questions, I think, which came out of the review of the abstracts. For gastroesophageal reflux disease, there's a quirky abstract I'm going to talk about, and that relates to the problem of refractory GERD. Is it all acid? How common are PPI-related adverse events? There's a cottage industry and doing meta-analyses and other things to determine whether or not PPIs are dangerous. Barrett's esophagus, how many pathologists does it take to diagnose dysplasia? And do we need pathologists to diagnose dysplasia? And for gastric intestinal metaplasia, how prevalent is GIM and is it important to diagnose it? So if I start off with gastroesophageal reflux disease, this is, I always put this slide in because I don't know any others, but this is basically the foundation of the management of reflux disease is what used to be the foundation of peptic ulcer disease management, which is that it's all about the acid, no disease. The problem is, although we've got used to very high healing rates for erosive esophagitis, our patients tend to be less sanguine about how well we're doing. And this is the sort of 8-week response rates for symptoms in reflux disease. So generally we tend to get people under control for reflux. Only about 2/3 of them are actually symptom-free or have good symptom response after 8 weeks of therapy. And there are many continue to have some form of symptoms. And so one of the areas that's being looked at is what are the other reasons why people have symptoms. So my research career, to the extent that I have one, started in London, and one of the first descriptions I remember from my boss was of the red-green bile acid stomach. This was the era when surgeons did nasty things to the stomach and they produced bile reflux that produced erythema, and the thought was that this produced lots of injury, including ulceration, and that this was mediated not by the yellow stuff but by the bile acids that were in there. So this is cholic acid, a couple of other derivatives. And it's the notion that there are things other than acid that has led surgeons to promote the idea of doing anti-reflux surgery because they're keeping everything nasty out of the esophagus, not just acid and pepsin. So one of the ideas that's been bounced around has been the notion of trying to mop up bile acids that are really probably the most toxic part of non-acid reflux using anion exchange resins such as cholestyramine. So the first abstract that we have is about a medication that rejoices under the memorable sobriquet of IW3718, and I've forgotten it already. So this is touted as a novel gastric retentive formulation of a bile acid sequestrant from ironwood, hence the IW. Ironwood brought you linaclotide as well. It's a bile acid binding protein modulator, and I tried to look that up and I got no idea what it is. I couldn't find anything about IW3718 other than the fact that it's wonderful. It's got a drug delivery system that keeps the drug in the stomach and in the duodenum, which is interesting. I can't work out what the technology is, but the notion is that it keeps the sequestrant in the stomach to bind the bile acid and stop it going up into the esophagus. And this was the background to this, therefore, is that bile acids may be an important contributing factor to refractory GERD symptoms of heartburn and regurgitation, and that this formulation may therefore be useful for improving symptoms in refractory GERD. And so this is a pilot study presented at a plenary session on Wednesday by Mike Vasey's group. They actually did Bilitech monitoring, which takes me back probably about 20 to 25 years. I don't know where they found a Bilitech monitor, but they did, and it monitors bilirubin, not bile acids. But it was a way of trying to work out who had pathological bile reflux, and they then randomized their patients to this IW3718 or placebo and monitored their symptoms. This really is an exploratory study, so there aren't a lot of hard data. They did their Bilitech monitoring, and they found that 33 of the patients it's 33 out of 52 who consented to Bilitech monitoring, that's about 2/3, were positive for bile reflux, and about 1/3 weren't, and the other 41 sensible patients refused to have Bilitech monitoring at all. At the end of that, they found that, and again, I don't have hard data on this, but it was sufficient for them to proceed to further studies, and what they showed was that the IW3718 appeared to be superior to placebo for engendering symptom resolution, so there's a high proportion was symptom-free at 4 weeks, and the highest symptom relief occurred in those patients who were positive for bile reflux on the Bilitech monitoring. And there are also changes and differences with respect to change from baseline, the severity of daytime regurgitation, and the number of days free of heartburn and regurgitation. There were side effects, so there's constipation was the most common side effect, which would fit with this being something that's probably similar to cholestyramine and cholestid or cholestipol. They said it was well tolerated, and it supports the hypothesis that bile acid sequestration may reduce reflux symptoms. I think there are a couple of challenges. I think it's interesting, it's always interesting to have a look at new ideas because most diseases are not a single pathology. I think it's going to be a challenge to work out which patients have bile acid mediated symptoms. I'm not sure that I see Bilitech being revived and brought back from the dead. It may be that we'll need to work out how to identify patients who have a chemical gastropathy related to bile reflux when we do endoscopy. And we still don't know, although it improves symptoms, whether it will actually reduce damage and reduce erosive esophagitis or have any effect on Barrett's esophagus. The other thing is that if it's anything like cholestyramine, that binds to just about everything, so the notion that it's specific for bile may also be a little optimistic. The next topic I wanted to look at was the notion that PPIs cause a whole slew of different complications. I think there's a reasonable data from a number of studies to show that PPIs and acid suppression increase the risk of enteric infections. The notion that PPIs lead to fractures, I think, is much more suspect, and this meta-analysis suggested that although there was a small epidemiological association, this did not constitute a causal effect and may well be due to unmeasured or residual confounding. On the most recent one, there's a couple of things that have come out this year. This one was a meta-analysis of, I started out with hundreds and hundreds of studies, but narrowed it down to 26 studies, in which the end of this, they showed that PPIs were associated with an increased risk of community-acquired pneumonia with an odds ratio of about 1.49. What was interesting from this is that they did not show a dose effect, so that the effect was comparable for high and low dose PPIs, that the risk was greater for the patients who just started PPIs, and that it appeared to disappear as patients were on PPIs for a long term, which is difficult to put in place conceptually, and there did not appear to be an age effect either. So they did say that PPIs were associated with an increased risk of community-acquired pneumonia and hospitalization for this. H2 blockers, they said, were not associated with an increased risk of community-acquired pneumonia. And they said, although there was no effective dose or age, there was an increased risk with recent PPI use, and they suggested that we should be really careful about using PPIs in anybody. This is another study, one of the early studies, which again suggested that the effect appeared to be early on in the course of PPIs, which there's been lip service paid to this, but it's has been postulated as a protopathic bias, and the notion is that the PPIs are started for some other process and therefore associated with an abnormal effect rather than being causal. The challenge for us is that this is a prolonged discussion I seem to have with just about every patient who comes into my office when I start them on PPIs or they want to continue, is to go through the litany of proposed side effects for PPIs. And this, I think, affects not just us as specialists, but also family docs. So looking at that as a base, this plenary session poster, or plenary session presentation, looked at this to see to what extent this information seemed to affect the prescribing practices of family doctors and GIs. So they basically sent out a survey to physicians at multiple institutions, and they went to a number of conferences, and they managed to recruit or get responses from 384 gastroenterologists and 88 family physicians. And what they did was to ask them how their prescribing practice would be affected. So what this basically shows is that GPs are much more risk averse in terms of PPIs than we are as gastroenterologists. And I would say our cardiology colleagues are also risk averse when it comes to prescribing PPIs. But basically what this red column does shows that the GPIs are much more likely to stop PPIs if they're concerned that the patients have osteoporosis, that they're much more likely to stop them for intercurrent infections, and in fact that they will seriously consider stopping PPIs if patients have cellulitis, and that they will switch from a PPI to an H2 blocker if the patient's on clopidogrel, and that runs around the 40 to 70% of GPs will consider stopping PPIs, even if these patients had severe reflux disease or at risk and had Barrett's esophagus. So the summary for this presentation is that American GPs express greater concern for adverse events than their GI colleagues, that this leads, or at least they say it will lead to discontinuation of chronic PPI therapy in patients, even those who are at high risk or have documented severe disease. And they say that clearly there's education needed regarding balancing the risks and benefits of PPIs. And my comment on this is that individual practitioners, and that I include myself in that, and patients find it difficult to assess risks, especially for rare events. And this is one of the challenges. So if you take nothing else out of this, one of the most interesting books that I've read over the last year or two is this from a Nobel Prize winner in economics, who is also a psychologist. And it's called Thinking Fast and Slow, which actually is a very good summary of the ways that we make wrong decisions based on the way that we're programmed to think. So there are a couple of comments from this. He says, a reliable way to make people believe in falsehoods is frequent repetition, because familiarity is not easily distinguished from truth. Authoritarian institutions and marketers have always known this fact. And our comforting conviction that the world makes sense rests on a secure foundation, that is, our almost unlimited ability to ignore our ignorance. So I thoroughly enjoyed this. So that's my take-home message. Find the book and enjoy it. And just to look at confounding, there's a poster here which is interesting, and this is really big. This looks at the association not between PPIs and respiratory disease, but actually between reflux disease and respiratory disease. And the bottom line for this is that both reflux disease and erosive esophagitis are associated with an increased risk of intubation and mortality from acute exacerbations of chronic obstructive pulmonary disease, and that there's therefore an independent association, it would appear based on this, between reflux disease and these complications of respiratory disease. That really has not been accounted for in any of the studies that have looked at the association between PPIs and respiratory disease. If I move on to Barrett's esophagus, we screen Barrett's because we're worried that patients will develop esophageal adenocarcinoma. And one of our challenges, at least in the patients whom we follow, not necessarily those that we don't follow, but the ones that we follow, is that there has been a steady reduction in the risk of esophageal adenocarcinoma from about 1 in 1,000 in the 1990s down to about, 1 in 100 annually in the 1990s down to about 1 in 300. So the risk appears to be diminishing, at least in the patients whom we follow and those whom we're treating with acid suppression. The risk is greatest, as you see on the bottom line, for those with dysplasia, rising to about 66 per thousand patients years, which is about 6% in patients who have high-grade dysplasia. And so one of the challenges then is to identify those patients who have high-grade dysplasia. The guidelines that I mentioned earlier, the Bobcat guidelines, said that single reporting of biopsies for routine diagnosis of benign Barrett's is satisfactory, and there was agreement among the participants in that. But what they said as a second line was that there should be a consensus between at least 2 specialist GI pathologists for a diagnosis of low-grade dysplasia. And the next couple of presentations sort of address this either directly or tangentially. So this study looked at patients who had a diagnosis of low-grade dysplasia or high-grade dysplasia, and then looked at what happened if they then had an attempt at independent confirmation by 2 further specialists who, or pathologists who had expertise in GI pathology. And so what they did was to go back to these biopsies and re-review them. So they had 352 patients with low-grade dysplasia that was diagnosed by the initial pathologist. And out of that, they then followed up 249 subjects whom they did a re-evaluation with their 2 expert GI pathologists. And the bottom line here is that out of those 249 or 250 who had been given a diagnosis of low-grade dysplasia, review led to over 25% of them not having a diagnosis of low-grade dysplasia. They had non-dysplastic Barrett's esophagus. Another third had indefinite for dysplasia rather than true low-grade dysplasia, and only just over a third actually had a confirmation of low-grade dysplasia. And as we move to ablation or to other therapies, this actually has significant influence and effect on which patients should be offered therapy, and goes back to the Bobcat guidelines that one should be looking at independent confirmation for this. So what they say is they had a large, well-defined cohort of LGDB patients, low-grade dysplasia patients. Additional confirmation by another panel downgraded nearly 2/3 of those patients from low-grade dysplasia, and that if they then identified those who were indefinite or truly had low-grade dysplasia, they had a much greater risk of progression, therefore identifying patients who A, should be followed more closely, and B, might require intervention. Again, the challenge here is going to be implementation in clinical practice. I can imagine trying to send everything off for 2 further GI pathologists to have a look at it, and then trying to identify 2 pathologists who actually will acknowledge to having expertise in this area. And it will, like everything else, require cost-effectiveness studies. Another approach, although perhaps not for Ontario, that appears to be extraordinarily slow in adopting any new technology, is this Watts 3D for low-grade, the diagnosis of low-grade dysplasia. And they again point out that Barrett's esophagus is a risk factor for low-grade dysplasia. They say that biopsying, even 4-quadrant biopsies, if they're done, only sample a very small proportion of the mucosa, and therefore it may not be appropriate for screening for dysplasia in patients with Barrett's esophagus. So this was a community study where they compared, I realize we probably don't have any sound, but this is a study where they compared the results from this Watts therapy with standard 4-quadrant biopsies to see what the pickup rates was for the 2. So this just gives a rough idea of what it is. This is basically, as you'll see at the end, is a brushing from the distal esophagus. And what they do is they then extract the cells and run them through a computer analysis to work out what their morphology is. So this here shows that biopsies only pick up a small area of the esophagus and are likely to miss abnormal areas. Although it has to be said also, studies suggest that if we look carefully, we won't necessarily see a yellow flashing light, but we can pick up irregularities in the mucosa which should be biopsied, and is actually rather like ulcerative colitis, likely to be much more rewarding than doing random biopsies through areas that look normal. So the notion here is that this samples a much larger area, that it's wide area, that it's transepithelial, and that they're then able to do something that probably looks a bit like, I'm trying to remember, cell cytometry. So they did a study where they compared 4-quadrant biopsies with this Watts 3D, and what they found was that there was basically a much higher pickup both for non-dysplastic Barrett's esophagus and for dysplasia. So there, and it's close to a commercial, I would confess, but what they say is that this increased the yield for all Barrett's esophagus by about 20% and increased the yield for dysplasia by 1.75%, which was about a 400% increase in the overall detection of low-grade dysplasia. And arguably this would then get rid of the need to have dual pathologists. It would actually just get a wide area sampling that would have a greater likelihood of picking up the abnormalities. Having said that, we need significantly more studies to optimize specificity here, and it's obviously not a substitute for biopsy in other conditions where one's looking for other causes of symptoms. It will not, for example, pick up eosinophilic esophagitis. So the last section I wanted to look at was gastric intestinal metaplasia, which is, this is just to make you feel seasick or you feel as though you're surfing and things are going up and down. It's rather like early gastric cancer. It's something I think that in North America we do not do a good job of picking up. I think it gets lumped under gastritis, and then I think the tendency is to not biopsy because we're not quite sure what to do with the results. There are a number of publications that have come out of Japan around this. This was an interesting one that talked about mottled patchy erythema, or what they call MPE, basically being a good endoscopic predictor of gastric intestinal metaplasia. And I've spent 30 years trying to avoid histology, and it still keeps coming back to bite me, but this is just to show that chronic atrophic gastritis in the context of producing intestinal metaplasia is a risk factor for the development of gastric adenocarcinoma. And the risk of gastric adenocarcinoma increases as the severity of the metaplasia and then dysplasia progresses, and patients who have severe dysplasia in the context of gastric intestinal metaplasia have about a 6% annual risk of gastric cancer, which is comparable to the risk that we talked about before of esophageal adenocarcinoma in the presence of low-grade dysplasia. There are a couple of abstracts here. This is from a plenary session on Monday, and what they say here is that gastric cancer is the 5th most common cancer worldwide, although the prevalence in the USA remains low. They say there's very little data on gastric intestinal metaplasia in the US, and therefore what they wanted to do was to do a local retrospective analysis of patients with gastric intestinal metaplasia, looking at predictors and trying to estimate its prevalence in a large tertiary care center. So they looked back over a period of about 22 years, and they identified 2,800 patients who had either gastric intestinal metaplasia, dysplasia, or gastric cancer. They reviewed the charts on 1,230 patients, identified intestinal metaplasia in 1,150, and in the rest there was 82 gastric cancer, low-grade dysplasia, or high-grade dysplasia. About 30% of these patients were HP positive. In terms of surveillance, surveillance was recommended only in about 17% of those who were identified with intestinal metaplasia, which I think speaks to our challenge of knowing what to do with the results. And even if we do identify these patients need surveillance, then the follow-up is actually pretty grim, because only about 40% of those in whom surveillance was recommended actually went on to have surveillance. So 7% of those identified with intestinal metaplasia actually went on to have surveillance. In looking at the risk factors, and I presume they'll present others, but they said that Asian patients in their area were constituted about 7% of all endoscopies, but actually were about 22% of the gastric intestinal metaplasia. And one of the things that's going to be interesting to hear from them is the extent to which this relates to Helicobacter pylori. They recommend greater adherence to surveillance recommendations and protocols. They talk about education and outreach to patients. And there is obviously the fact that sampling the stomach, if one has difficulty doing 4-quadrant biopsies every 2 centimeters in the esophagus, this is an impossible undertaking in the stomach and will probably lead to me being assaulted and thrown out of the unit by the nurses if I were to attempt it. So we need other wide area screening tools, or we need other ways of trying to identify patients who are at high risk. One way is to go around it to do this endoscopically. The other one is to try and see if there are other ways of identifying patients who have a higher risk of the end result. That is, going directly to work out those who have early gastric cancer rather than trying to set up patients for long-term follow-up for biopsies for intestinal metaplasia. And there have been a number of approaches to this. This is by no means unique, but this at least has the advantage that it looked at patients both in the US and in Korea. And what they did here was to take some gastric biopsies and then to analyze those for methylated markers as precursors for the occurrence or indicators of a risk of gastric cancer. So they identified some methylated DNA markers by going through, and this is another ohm that I'd not heard of, they went through the whole methylome. I hope that's not the home for methyl alcohol, as beloved of people under bridges, but anyway, we'll hear more about methyl homes at some point, I guess. So they went through and they identified 17 markers. They picked out 10 of those that they felt were, or they identified 17 markers. They microdissected their tissue. They had gastric cancer patients from the US. They had healthy controls from the US. And from Korea, they had patients who had gastric cancer, and they took other tissue from areas that was not affected by the intestinal metaplasia or other abnormalities. And they did a whole series of AUC, ROC curves, identified 10 markers. And really, the interesting thing, I think, from this is that at least in this patient population, they were able to identify 100% of the US and 95% of the Korean patients with 95% specificity, suggesting that there may be ways, other technologies appropriate for identifying patients at risk of an adverse outcome rather than trying to do repeated endoscopies with multiple biopsies. So the perspective that I'd put on that for gastroesophageal reflux disease, refractory or persistent GERD is a challenge, and I'm not sure that bile acid sequestrants are going to help us too much, but I watch that with interest. Balancing cost and benefit and risk for diagnosis and therapy will continue to be a challenge, despite the fact that we have good therapies for many patients. We need novel approaches to managing dysplasia, which are both technical and operational if we're to optimize outcomes for patients with Barrett's esophagus. And we need to know a lot more about gastric intestinal metaplasia, whom to look at, whom to biopsy, and then what to do with the results, because at the moment I think we ignore it. So I'm going to leave you with Hawaii 5-0, which is where I first watched Hawaii. Was in Germany. Aloha. Mahalo is apparently thank you. And enjoy Honolulu. Thank you.
Thanks very much, David. We probably do have time for a couple of questions over here.
Right, I was yes, I'm trying to repeat the question. So I think if I summarize the question is, it's all very well talking about gastric intestinal metaplasia, but how do we manage it, given the difficulties biopsying, and then how to communicate that to patients without frightening the life out of them. So I'm not sure how best to do it. I think what we really need to do, I think one of the things is we need some better guidance around this, which is not to try and pass the buck, but it's really to have a framework or a structure around the way that we deal with this. Because at the moment what we do is we ignore it. We hope that if we ignore it, it'll go away. And it's a discussion I remember having about 15, 20 years ago around Barrett's esophagus, where a number of my colleagues said, I don't biopsy it because I don't want to find out what it is, and I don't want to then have to explain to my patients what they've got and that they need repeated endoscopies and biopsies, and it'll impinge on their medical insurance costs as well. I think we've got some data, and I alluded to this, which is that patients who've got high-grade dysplasia have an increased risk of about 6%. 5-6%. Those who do not have dysplasia probably have a very low risk, which is down in the area of patients with Barrett's esophagus. And when we follow patients with Barrett's esophagus, there are a couple of things. One is we don't necessarily have to commit them to lifelong surveillance. The data suggests from Barrett's esophagus, for example, that if somebody who's had 3 or 4 negative surveillance, that is no dysplasia from Barrett's esophagus, has a risk of developing esophageal cancer, which is down with the rest of the population. So if you do, it's not committing people to lifelong surveillance, it's really saying if we look carefully over 2 or 3 scopes, then we can actually park this and it's not a problem. And I think what we need to do is to look at the same approach for gastric intestinal metaplasia. Because at the moment, the converse to that is we don't do our patients any favors. What we do is we scope them and say, well, don't worry. and a small proportion of them should worry, and we need to work out how to biopsy them so that we can then manage them.
Thanks very much. Thanks, David. Great. So let's move on to the last section. So we'll try to get through this quickly so we can get you, those of you who are physically here, onto the beach, and those of you who are online at home, get you to bed. But I'm going to briefly take you through a little summary on subsequent entry biologics. And one of the things the CARE group does intermittently is focus on a particular topic we think is of interest. And we've done this with constipation, as Louis Lou showed you earlier. We've also done this with risk assessment, for example, in Crohn's disease. And another topic we thought has been of interest to Canadian practitioners, and to some extent, it also is looming in the future for those of us who are not interested in subsequent entry biologics at the point. We thought it's an important topic that we should discuss so that we all have, I think, reasonable knowledge of the issue and we can have an intelligent debate. I'm going to talk to you a little bit about subsequent entry biologics then. So take you through these topics, I think, very quickly, and we'll, again, try to get you finished on time. So why the focus on SCBs? Well, first of all, there is a CAG position statement on this topic that Drs. Bressler and Biton have been CARE faculty members over the years, are members of this working group that published this position statement on behalf of the Canadian Association of Gastroenterology. Shane Devlin was the first author. A number of other individuals contributed as well. But moreover, SCBs are entering our market because of the expiry of patents of many of the innovator biologics, and this is going to change our treatment landscape very much. So these have a number of different names. In Canada, we refer to SCBs. US, the less friendly term, follow-on biologics. The Europeans, always being a little more sleek, have a nice clean name of biosimilars. And the WHO, though, refers to similar biotherapeutic products, a little more bureaucratic perhaps. But what are these? An SCB is a drug specific to biologic drugs, obviously, that enter the market after a version of that product that's already been authorized in Canada. So that initial version is what we call a reference biologic drug. So a different version of that drug subsequently entering the market is an SCB. And the crux of the debate on this issue is that subsequent entry biologics are similar to the innovator biologic, but just because of the nature of what a biologic drug is, can never be identical. And this reflects the fact that SCBs and biologics in general, the name biologic comes from the fact that they're actually produced in cell lines, so by living cells. And so those little differences in nuance of cell lines and the manufacturing processes around these cell lines have to be tightly controlled to limit differences in the end product. So for clarity, I think many of you have seen these sorts of summaries before, but it's critically important if we're going to have an intelligent debate on this issue that there's a difference between SCBs and generics. I think a lot of us, our patients, are saying, reading in the newspaper, that there's a generic now to one of our anti-TNF therapies. And well, technically it's not a generic. So generics is really a terminology that should apply to small molecule drugs. These are the things that you can cook in your kitchen, that Walter White and Jesse could make in a Winnebago in the desert, because it's a purely organic chemical process to synthesize this drug. And these are small molecules that can be fully characterized. The mechanism of action is generally well understood, and so it can be well characterized. And to approve a generic, you really just need to demonstrate that there's similarity in bioequivalence for the actual product. So SCBs are a little different because biologics by nature are larger molecules, are more complicated, manufactured in a living system. So if you think about large complicated proteins, primary structure, secondary, tertiary, quaternary structure, post-translational modification, all these things come into play. So it's challenging, if not impossible, to duplicate exactly. So the approval process has to be a little different too. It's not just trying to show some basic equivalence in pharmacokinetics. There's also a process of trying to show clinical and non-clinical comparability in human patients. And the question really is, how far do you have to go down that pathway to reassure ourselves that the SEB is sufficiently similar to the innovator biologic for use in patient care. So the current state of the union, if you will, in Canada and throughout the world is that each regulatory authority, and Health Canada would be ours, has had to develop specific standards and guidelines for the approval of SEBs. And so Health Canada has gone through a long process of trying to develop their own internal process for approval of SEBs. Now, present in the US, no SEBs have been approved since FDA developed their own guidelines. There is actually, you may be interested, Neupogen has had a preliminary approval from the FDA subcommittee, and so that may prove to be an analog to Neupogen, may be the first SEB approved in the United States under these guidelines, but so far none has been approved. 5 have been approved in Europe, including 2 for anti-TNF therapy, and 1 has been approved in Canada. It's biosimilar to Remicade, and we'll talk about that at the end. But for treatment of IBD in North America, that is neither in US nor Canada has any SEB then been approved for treatment of IBD, and we'll come back to that. So the analog to Remicade in Canada has not yet been approved by Health Canada for treatment of IBD. So as gastroenterologists, we're a little insulated from this, but you know, for sure this is coming down the pipeline. So just briefly, Health Canada guidelines, and again, I'm not going to go through all these points in the interest of time, but Health Canada has a process for approving biologics that requires both some basic science and some clinical data to demonstrate equivalence. There's a bit of wiggle room in the guidelines as to what sort of clinical data would be required to support equivalence. But at the end of the day, Health Canada is quite clear that SEBs are not generic biologics. So there's a difference between an SEB being approved for a biologic and a generic being approved for small molecule therapy. And specifically, the approval does not declare the SEB to be equivalent to the reference biologic drug, simply states that it's sufficiently similar to be used in practice. And that boils down to these last 2 points here, that SEBs, according to Health Canada, should not be labeled as interchangeable with the reference biologic drug and hence should not be automatically substituted. So if you write a prescription for a reference, it should not be automatically substituted with the biosimilar. But Health Canada really doesn't have jurisdiction over this. This is a provincial issue, and so it's going to be provincial drug plans and ultimately private drug plans as well. They're going to determine the place in the market. But Health Canada does not endorse or support this idea of interchangeability. So there's some challenges in Canada, but there's potential benefit to biosimilars. I want to be clear about that. This class of therapy, biologics, I think this has been a theme through the presentations today, have really improved health outcomes of patients with IBD. And those of us who've been in practice for a while, and I guess it's the faculty for the most part, exception of neurology, have really seen a change in the outcomes that can be expected in patients with IBD. It's been a huge, really revolutionary change in IBD. But you know, there's an issue there, and we also heard about that today in terms of rising drug costs and acquisition costs. And so SEBs do have a potential role if they come in at lower cost to help offset those direct costs that we heard about, and perhaps even improve access to biologic therapy and sustain access within provincial formularies. So there's a potential benefit to SEBs, but really those benefits are contingent on us assuming that there is equivalent efficacy and safety both in the short and the long term. So there are a few different challenges here. If you go around this circle, first of all, at the top, what are the data that require approval, required for approval of an SEB? What evidence does one need to declare that biosimilar is sufficiently like the innovator to enter the market? Second is, how do you follow these things after their entry? And this has been a huge matter of debate because currently the generic name for the biosimilar is the same as the generic name for the reference biologic drug, which is Infliximab or adalimumab. It doesn't differentiate the two. And if we're not quite sure that these are identical molecules, there isn't currently a pathway to track outcomes in the world separately because they have the same generic name. And this has been an issue in that INN, that unique naming system. There's been an argument in some parts of the world that they should be named differently, perhaps Infliximab, Infliximab alpha, Infliximab beta, for example. But so far that has not been taken up. So we have a problem in post-marketing surveillance. And then the other issues relate to what we talked about before, substitution, and something else I'll touch on just briefly, which is extrapolation. So I think I'll skip this slide, which just defines what interchangeability and substitution are in the Canadian landscape. And I think you've seen this with other classes, particularly, for example, with PPIs. But one of the issues with SEBs and substituting back and forth between an innovator biologic and an SEB, one of the concerns relates to immunogenicity. And we all know that in the long-term success of biologic therapy, we've come to recognize that avoiding sensitization and immunogenicity is a significant predictor of long-term success of biologic therapy. Patients who develop antibodies against biologic drugs, sometimes those antibodies have no effect, it's neutral, but they can also have effects on pharmacokinetics, on efficacy, and potentially in some rare scenarios which have been reported, cross-reactivity with endogenous proteins as well. So avoiding sensitization is a key point. And it's not clear yet whether switching back and forth between an SEB and innovator biologic would have any effect on long-term sensitization to either the innovator or the biologic. So in this class of therapy, one of the issues for debate is that we have to think carefully about interchangeability and substitution. First of all, as you'll see in the Canadian landscape and other jurisdictions throughout the world, not all the indications for a reference biologic drug are actually shared with the SEB. So there's some conditions for which by approved indications one can't switch back and forth even if one wanted to. Because of these differences in structure, there will be subtle differences between SEBs and reference biologic drugs, which could lead to differences in efficacy and safety, and they may or may not. I mean, interpret these data, but there's that is for discussion. And the immunogenicity argument that you can't really assess long-term sensitization in some of the shorter-term clinical trials, which so far have been published, and we know very little about the cross-reactivity between antibodies formed against the innovator biologic and the SEB, whether those antibodies cross-react with either the SEB or the innovator biologic. And so switching back and forth, we really don't have a good handle yet on what the impact might be on sensitization. So that's, I think, one of the issues. The other issue is around extrapolation. And again, just in a couple of minutes, it's an interesting phenomenon, and it surprised many people in this arena that regulatory authorities around the world have approved SEBs for sale with approved indications that are held by the innovator biologic without actually evidence for use of that SEB for that particular indication. We'll give you some examples of that. So the SEB is studied against the innovator biologic in disease A, yet it's given approval not just for disease A, but disease B, C, and D, all the indications for which the reference biologic has been approved. That might be justified, and each of these regulatory agencies goes through some decisions about what the mechanism of action is, what the pathophysiology of the disease is, potential compromises in safety, and what clinical experience has been with the reference biologic. And all these sort of come into a decision by the regulatory authorities whether it could be approval for other indications. So again, just briefly, this is a reality in Canada already because CTP13, many of you may know as Inflectra, has been approved in Canada as an SEB to Infliximab. So it's a biosimilar to Infliximab. It's an interesting process, and again, this is some of the debate we can have, that this molecule was approved for treatment of a number of indications. I'll show you the approval in Europe was for all indications held by Remicade, yet the only clinical data at the time of approval were two trials. One was a phase 3 clinical equivalence trial in rheumatoid arthritis called Planetra, and the other was a phase 1 PK study in ankylosing spondylitis. So based on those two studies and those indications, this molecule is approved for all indications held by Remicade in the European market. It's interesting, Health Canada did not approve this molecule for treatment of inflammatory bowel disease, and that's why we as gastroenterologists haven't had to deal with this to the same extent. Health Canada did note some of the data provided showing differences between the SEB and the innovator for some of these things listed here, but particularly antibody-dependent cell-mediated cytotoxicity. There's some nuances and difference there, and there may be more of a pivotal role for that pathway in IBD compared to other immunologic disorders, and hence Health Canada didn't feel comfortable approving the SEB for treatment of IBD, and this is the reason why we haven't seen it. But if you look at what happened, again, this is a Korean company that created this SEB. In Korea, it was approved across indications with the exception of pediatric IBD. In the European market, it was approved for all indications held by Remicade, and in the Canadian market, approved only for the rheumatologic indications as well as psoriasis. So rheumatologists and dermatologists are seeing this in their practice. This is, again, just the tip of the iceberg. Remicade patent was expired in Canada a couple of years ago, and this is why we're seeing the biosimilar to Remicade first. Humira's patent is ending in 2017. It's the #1 drug in the world by sales, and so there are many companies keen to get into that market. So in fact, nearly 50 biosimilars to adalimumab, which are in various stages of development. This slide just lists some that are in more advanced stages of study. So get ready in 2017. We're going to see a very different landscape in the market. And that's why I think it's critical that we as gastroenterologists, as well as rheumatologists and dermatologists, have a good understanding of that issue so that we can have intelligent debate. Again, it may be a very good thing that we see competition in the market and that we see other alternatives for patients, but we have to know the questions to ask and we have to be able to have the right discussion. So again, we had planned to have a little bit of an open discussion, but in the interest of time, I think I'll just take you through some of the questions that you can mull over while on the beach tonight at your luau, and I'm sure these will be top of mind. So I think these are questions I think come to my mind. What evidence is sufficient for approval of an SEB in any market, particularly in Canada? What do you, as a clinician, want to see before you'll consider allowing your patients to receive an SEB? Is extrapolation across indications reasonable? At one extreme, you could say every SEB should be studied in every clinical condition with a head-to-head 1,000-patient clinical trial, but that's also not possible. So at the end of the day, probably should be some compromise here, but how much of a compromise are we willing to make? Are we willing to use a product in IBD that's never been studied to date in a patient population with IBD? What are the consequences of switching between the innovator and an SEB back and forth? I think many of us are quite reluctant to see that happen. A stable patient on an innovator biologic, I think switching to an SEB, do we want to risk destabilizing that patient, potentially sensitizing the patient to the innovator if there are differences in structure? Another scenario would be the new patient starting on an innovator versus an SEB. That may be a little less controversial, but still, are you comfortable seeing that happen? If a patient loses response to an SEB, so if our insurance providers require us to use an SEB first at some time in the future, patients lose response to an SEB, can you use the innovator to that SEB as a second-line therapy in that patient? Is failure of the SEB sufficient to predict failure of the innovator? I don't think we know the answer to that yet. And I think all of us should think at the end of the day, how should we be studying these molecules? What kinds of trials would you like to see of SEB? So we won't hold a discussion here, but I'll let you take those questions home. So just quickly what the CAG statement presented. Those of you who saw it a couple of years ago. Again, the first bullet's, I think, important that SEBs are potentially effective and cost-saving. So there may be a role for SEBs in our marketplace. This is a reality. We've got to do something to deal with spiraling drug costs. But they should really be regarded as standalone products, and they should be supported on their own evidence for use in Canada. Should not be regarded as interchangeable with the reference biologic and should not be automatically substituted. There should be a process for long-term phase 4 pharmacovigilance, despite this issue in nomenclature that I alluded to before. We have to think of strategies to track long-term outcomes to see if these concerns actually prove to be true or not. And that another, I think, point made to these guidelines is that the innovator biologics, rightly or wrongly, have had to develop support systems for their products. And we would hope that an SEB in the Canadian market would provide similar support for patients, because I think what we've learned is that biologic therapy in Canada is not just the product, it's also the support for that product in terms of delivery and battling insurance. So the SEBs, we hope, would come with a similar support. So that's really all we wanted to go through tonight. There's a couple of summary points here, but we as the CARE group are going to be having some more discussion of this issue over the coming months and year, and would welcome your input. So that needs assessment that you saw addresses this issue. That will actually be mailed out across Canada to try to solicit some opinion on the issue, and we really look forward to that so that we can develop some, I think, some statements, perhaps some guidance that can be useful in the Canadian market. So with that, really I'd like to bring to a close the CARE meeting for ACG 2015 in beautiful Honolulu, Waikiki. I can actually see the beach where I'm standing. It's quite tempting. But I'd like to thank all of you who are in the room for coming out and asking some great questions. All of you who, if anyone is still up listening online in the webcast, thank you for that. And for everyone, all these presentations will be available through the CARE YouTube channel, which can be accessed through the careeducation.ca website. So I'd like to also thank our sponsors, we named at the beginning, for supporting the program and all of the services that come with the CARE program. And also like to thank the people from Converge for all the logistics in making this meeting happen. And with that, aloha and have a good evening. Okay. Thanks.